And then, oh, go ahead.
Go ahead.
I was just going to say, for roll call purposes, please put your name and who you're affiliated with in the chat, and that would be gratefully appreciated. Thank you. And I will be quiet now.
We'll get started here in just a couple minutes.
Walter and Janet, I don't know why it's doing this, but it's on my side and letting people in.
Oh, I'll take care of that, George. I'm monitoring it as well, so
Okay.
I'll allow. Oh, thank you though for letting me know.
Okay.
Jake, I'm gonna do now what my wife likes to do. I'm gonna mute me, and it's your show.
We'll give it just another minute here for anybody else that's still joining. We have quite a few clicking in here. All right. We are at 1:05, so thanks everybody for joining today. We greatly appreciate you joining the Integrative Care for Complex Populations Collaborative. I said that without tying my tongue up, so that is a positive. As it's been noted by Walter or Janet earlier, if you're just joining, please make sure you put your name and CCO affiliation in the chat. We greatly appreciate it for the ability to take roll call later. And we have first up on this is our introductions. So again, I'm Jake Vandermeer. I'm a Pacific Source CCO affiliate and one of your co-chairs. And I'll kind of hand it over to my other co-chair to introduce himself and then over to our fearless leader.
Good afternoon, everybody. Walter Burkhartsmeyer, and I am with Care Oregon. You're up, Janet.
And I'm Janet Herb. I'm with Oregon Health Authority, and I get to support this wonderful meeting.
Thanks, guys. For our agenda today, we have Jennifer Valentine doing an update on the MOU. We have Charissa Young-White from OHA to talk about OPN and HRSN, or OHP HRSN. Do a quick bio break in the middle. We have a discussion from Dar and Nirmala around slums, cognitive screening tools, and billing guidance. Understanding 99483, just to do with OHA billing code requirements and credentialing details. And then we'll get into a discussion around interpreters in office, open discussion on successes and challenges, led by Nicole Tui. And I probably butchered your last name, so I apologize for that. I'll let you. I got a head shake. I may not have butchered that, hopefully. And then she is the VP of Customer Experience for Care Oregon. So thank you for joining us today. We greatly appreciate it. And then lastly, we'll get to public comment if time permits. So without further ado, we'll kick it off with Jennifer Valentine. And I believe I saw you jump on.
Yeah, hi. Sorry it took me a couple minutes to get connected here today. Folks, I'm going to go through some slides, so I'm going to share my screen. And these were not sent out in advance, but we will get them out to you. I'm going to kind of walk through very quickly some of the issues around your MOU updates for the CCO LTSS MOU. Those are due, the updates are due on the 31st, I believe, of March. And the updated guidance for the MOU, a memo about the MOU, and the template were all posted and emailed to your CCOs on December 31st. So you can find those documents in the on the CCO forms page. And I want to clarify too that there is the separate timeline for MOU reporting, and reporting is due, the annual report is due on May, at the end of May, I believe the 30th of May. And so
Jan.
that reporting will be for the calendar year 2024. So we'll be reporting on last year's. The guidance for that and the report form are being updated and reviewed right now by the CCO quality team. So those will get posted, I believe, by the beginning of March. So stay tuned for that. But today I want to kind of walk you through just some overview issues, be available to clarify, and of course remind you that anyone who would like me to meet with them about their reports that they got or any of the issues, we would encourage you to do that. So let me see if I can get this into slide mode.
We can,
Always forget
Jennifer,
where to
just so
find
you
it
know,
again.
we can see your chat screen. There you go. Now we see the slides.
Can you see it? Can you see the
Yep.
MOU slides? Okay, I'm just trying to find the slide mode here. Okay. Okay, so can you see this presentation now?
Yep. It's
Okay.
good, Jennifer.
All right. So we sent out a memo that said the areas of emphasis for your improvements of your MOUs. Now, so the MOU template has not changed much. And the guidance for the main 5 domains are the same. These are domains that were agreed to by the legislature, by the Health Policy Board, by CMS when we started CCOs. So, we've tried to update some of the key things, but we also want you to use your now 3 years of reporting to focus on where are the weaknesses in the MOU work. The MOUs are only documents. They are documents that are meant to guide the process of actual work to improve the outcomes for members who have LTSS and our CCO members. So the goal is really to make those improvements for those members. And so you can have, the MOUs are a paper process, and part of the reporting, the connection there is that we're trying to see how the MOU is working in real life. So that's kind of the connection between the MOU. So that's why when you're looking at the feedback you're getting on your MOU reporting, it can help you look at where you can make those improvements. So, we want you to look at your places like communication with the local offices. It's not enough to say, well, they never contacted me. Your MOU should really, and you should really work every year to make sure that there's a clear process and that the field offices feel comfortable. Some of them have had bad experiences in the past trying to send information for a member they felt needed communication for a high need, and they never heard back, so it really takes an outreach and building those relationships. So we really want you to work on that relationship process and have everyone comfortable with that. Also, I know many of you have been working on building your ability to track that communication. That has been a requirement in OAR since like 2017. So it's not something new, but has been continued to be a process that we've been trying to highlight is a key to the success of a communication. We also you have these hospital event notifications, and you have skilled nursing facility notifications that are part of the Point Click platform. And that these are a place where we hope you are using it to trigger your communications, especially around the care setting transitions. And I'll talk a little bit more about that in a few minutes. Ensuring that you are developing your care plans. The CY 2024 updated rules highlight that every member with LTSS needs to have an annual care plan. So you actually should have more care plans going forward as of CY 2024 for these members based on those updated rules. There is also this requirement to have IDT meetings after any care setting transition within 14 days for any member. So that is an updated rule. And so those are some highlights there. And then the other piece is we now have these waiver services that are new. And so how do you connect with your local offices and make them aware of what those services are and how to connect with you? So those are some key areas that we're going to look for when we review your MOUs that you're addressing and how you're improving the communications. You can start with your existing MOU because it's not, your processes. Many of you have really worked on those processes. We've seen some real improvements over the last 3 years in your sharing of prioritization and some of your outreach. So those things, we want you to look at, but also that your MOU process, you shouldn't be waiting till the end of March and contacting the local APD office and asking them to sign an updated MOU. You should be contacting them now, setting up meetings, listening to their concerns, and working toward that process of how do we build this as a team. I just wanted to showcase, this is one of the examples of from CY 2022, where we looked at the number of care plans across CCOs that were being developed for members with LTSS that you reported in your reports. And the actual number of comorbidity of 4 or more chronic conditions. That's the brown line. The blue line is anyone with SPMI, and the orange line is those with chemical dependency. So one of the other things is that many of these members have other comorbidity issues. So another reason why they should be hitting in your new prioritization a higher level of, not just because of the LTS, but because these are members who also have these other conditions. So when you're reporting these members into your annual reports, be thinking of how you are tracking anyone with LTSS who also maybe you're addressing them because of one of these other chronic conditions you've prioritized in your care planning. But just to, we've tried to highlight that. I think that was Jake, you had a question?
Yeah, I was just going to give you a time check, let you know we're at 1:16. We have a couple minutes to spare before we move to the
Okay.
next one. But
Well,
give
I
you a
got
couple
a
more.
little bit more than maybe you're ready to hear today, but I do think this is critical because these reports are coming up. Just some other examples of your tracked referrals. This is again where these are very low numbers. And this is again that place where some of you have told us you're building your system, you're not able to properly track. Shout out to Umpqua, who made huge improvements there in 2022 to track their referrals for LTSS assessments. I also want to send out to you that SB 296 is up today in a hearing. And SB 296 is the legislature, after they had a study, interim study committee on hospital discharge. There's a number of additional things they're going to be expecting us to study in that bill that's up over the next couple of years, and to build some additional tracking mechanisms for referrals to LTSS at hospital, as that, hospital discharge. So just, a note that we've been trying to build these things in, and that others are paying attention to these things. Just an example of one CCO this year for care plans compared to the orange line there is the overall number of members with LTSS and the number of care plans for members with LTSS that was reported. So we would be expecting in the future that these would be much higher as you work through the new OARs that require everyone has an annual care plan. Again, this is kind of similar, same thing. Just to highlight care setting transitions, and in your updated OERs, they are this critical period that is mentioned, how to define any transition from one setting to another, SNF to home, that's skilled nursing facility to home, hospital to skilled nursing facility, adult foster to another setting. So there's a lot of transitions, and so we would hope you'd be looking at how you're tracking those transitions. Just to note again here, this is the care setting transitions. It does require within 14 days of your transition that you would have an IDT that includes the member or their representative, and that you're talking about the clinical things. But again, it also highlights another weakness we've seen in some of your reports, that you've had a low number of members in your IDT meetings. So this is again highlighting these new rules that were in, this is since 2024. And this just shows again the lower communications. This is not the best way to report this, but to get everyone's CCOs in there. So you can see some of you actually did better in these are 2021 and 2022. But many of you still have a low number of communication compared to at discharge compared to actual discharges that are happening. Another way to look is your point click data. This is an example. If you've had this many triggers from point click, but your communication with APD is near zero, these are places to really focus on again and building that into your MOU. Again, reminders of your timelines. Your 3/31 is when your MOU will be due, and then 5/30 is for the annual report. And look for the additional guidance for the updated MOU report form. We are going to take some things that we feel are no longer relevant out of that MOU reporting, so you'll be excited about that when you see it. We're happy to share and meet with anyone again if there's any questions about that. We probably won't have another one of these meetings before then. So I'm happy to meet with anyone who has a question about that report form. I just also want to mention, this is going to be really critical, is making improvements on the LTSS indicator. Many of you have asked OHA, how can we get better data? And we, as the people who are working with our teams internally, need you as CCOs to remind our leadership. That could be Bonnie, who's Bonnie Barone, or I will try to send you guys. I'll put some other names in the chat. Your account rep. That you as a CCO want to see us improve this, because I got asked, even though this has been an ask since of us that I have heard since we developed the indicator and it was available in like 2018, that you've asked us to make these improvements. So we really want to move this forward so you get better data. So right now you're getting the LTSS indicator on your 834. It says they have, it's a yes or a no. They have a program. It doesn't tell you the program. We feel like that's not the best way we could do this for you. So what is our goals for updating this? Our goals are to try to get you better data we feel like you could better use this information by having an idea whether the program that they have is a DD program, or it's a 1915I, which is the behavioral health programs, or it really is an APD program, because right now you're getting a mix of programs. So we have this action step of we've met with APD to go through, try to figure out the codes. Again, I don't have a lot of time today to go through this because this is an add-on to your agenda today. You have this information in your You have this information in the has been in the guidance for that has been posted on the LTSS page and was given out originally in 2020. This tells you what programs do report. The problem is you're not getting this LOC code, so you don't know which program. You just know they have one of these programs. So it makes you have to work harder with your local offices to try to determine which program they have. And we would like to see that from our end as staff. We'd like to see that improved for you.
Hey, Janet, sorry, but we're reaching time on this,
Yeah,
and I know
and
we have at least one question
I'm
out
having
there.
trouble here because I'm kind of stuck. But anyway, there is this long list of programs that can report. So I'm going to leave it here and just say we encourage you to reach out to let us know that you are still interested in us making this better for you. So what you would get is you would get a list of codes, and you would get a list of, for example, all the DD programs. And so who should you connect with? You should connect with your local DD offices or the state DD office, or you should connect with your APD office if it's a nursing home program, for example. So that's kind of, you would get more information that you could use for your prioritization system. So I know we don't have time. George, I don't know whether we have time for questions today. So I'll leave that to the chairs, but I'm going to stop sharing, and we will get this out to you. Thank you. And again, if anyone has further questions, you know how to get a hold of me. I'm on the list of most of the documents that are out there for the LTSS in terms of contacting. So thank you for squeezing me in, and I better get off the horn here.
No, Janet, first of all, or not Janet, but Jennifer, thank you for taking the time, and how quickly you worked through that was quite impressive as well. I believe we have time. We'll take one question real quick from George before we move on. So George.
Yeah, my question is to Jennifer. How is the CCO MOs connected with AAAs in some way? How are they connected?
So the MOUs are by region. So in some regions there are AAAs, and in other regions there are APD offices. So each CCO is connecting with the offices. So some CCOs have more than one MOU. You can look at, I will go ahead and find the link to where the current MOUs are posted. So you can see the ones that are posted, George. They've been posted for, I think, a couple years, the ones that have been in existence. So I will send you that link, and then you can see that each CCO may have more than one, and they're with the local offices. They can also do a combined MOU, but they can also do a separate MOU with each office. If they do a combined MOU, they just have to end up having everyone sign it. So we offer some flexibility there, but yeah, it is AAAs and APD offices.
Thank you.
Thank you. Thank you for answering that, Jennifer. We greatly appreciate it. And George, good question. Jennifer, if you could send that slide deck around for everybody to have it, and then that way we can make sure that questions come back to you as well after that's published. So thank you so much. We will move on to our next item, and that is we have Charissa Young-White here to talk about HRSN updates. So thank you so much for joining us today.
Sorry, getting shared and trying to make sure I can unmute myself and everything. So I know Jennifer had so much good things to say. I'm sure I have good things to say too, but I honestly was expecting to talk with you folks around 20 minutes. I probably don't have the full time, so I think we'll make up that time again. Charissa Young-White, my pronouns are she, her, hers. I think most of you have met me in this space before, and I'm going to talk about health-related social needs. And I'll talk a little bit about some of the benefits. I'm going to talk more about updates and talk about the provider network and things like that, more than just a basic, what are these benefits about and how are you eligible? So I just wanted to be really clear. If you want more information like that, I would love to send you it. Please email me. There is lots of information on the website, and I also have a bunch of slides in the back of the deck that has some resources for you as well. So you probably know this already, but health-related social needs, they are things that are historically have not been covered under the Oregon Health Plan. Things like rental assistance or air conditioners to maintain a safe and healthy temperature in the home. Nutrition benefits, which at some point will include pantry stocking and a fruit and vegetable benefit. So look forward to those. But for right now, it's nutrition education and medically tailored meals, for instance. There's also outreach and engagement services, which is essentially resource navigation. So connecting to things like APD, for instance, that can help with lots of resources for people that are in these populations that we're trying to serve. And speaking of the populations, this is a benefit, an entitlement for Oregon Health Plan members. So if they qualify and they ask for these services, they receive them. There's no, discretion for denials by the coordinated care organization or open card. So it is a benefit, which is exciting. It's the first time we've had social needs be a benefit before. So there's those four things here. I wanted to quickly talk about the timeline. Since March, the climate benefit has been live. I'm going to skip through a couple slides here back and forth for just 1 second. And then a small piece of outreach and engagement services went live as well in March of 2024. So for climate, we are here at the state level. So we need to gather information from our members through our coordinated care organizations and over to us. So this data is a little delayed. We don't have the most recent numbers, but over the summer, we had about 3,700 climate devices delivered, and about 1,800 of those, maybe a little less, were air conditioners. People also received air filtration devices and air filters, so that helped with some of the wildfire smoke in many regions. And then also mini fridges for medication like insulin or something for people that maybe are homeless, but they have a place to plug in and they really need that refrigerator. So something like that. We handed out some of those as well. And heaters, potentially we delivered some in the summer. I can't quite recall, but I know in the winter, when we get our numbers from the winter, we're probably going to have quite an uptake in the heaters. It's been very cold. So these help people keep safe and well as it relates to heat and air quality, etc. Okay, now I'm going to go back because that was my quick climate update. And then we're really going to talk about what's happening right now. So November 2024, the housing benefit went live. I'm going to talk about some specific challenges with that piece in just a moment. But this is rental assistance, tenancy supports, which is basically helping people understand their lease, maybe sign a new lease, gather documentation that their landlords might need, anything that could be related to keeping someone stably housed and to help them. So it could actually be related to a job and income as well, because we have to have income to pay our rent, of course. And so getting support with, it's not just here's the place you live in and here's how your landlord wants you to behave, etc. It's bigger than that. It is, here's the place you live in, here's how you interact with the world, and here are some things that we can help you with to ensure that it's stable, comfortable, safe housing. So, having a job, like I mentioned, and steady income is part of that. So people can get access to navigation, housing professionals that can support with that. There's also the ability for home modifications. So like a wheelchair ramp, we've had a lot of those be covered by this so far, which is exciting. We won't have numbers quite yet for the reasons I mentioned, but we can come back here probably in 3 to 6 months and provide some more updates anytime you would like us. Although I heard you're not meeting for another 3 months, so maybe I'll be the next meeting you have. You never know. We also have a lot more outreach and engagement services that went live as well. And this is a little bit of a behind the scenes benefit. Members might not know as much about it, but it can really help folks connect to resources and continue to be stably housed or get access to nutrition that they need, etc. Because these are people that are currently working they're supposed to have lived experience and understand the region and the community they serve as well through the outreach and engagement services. And those folks can now get paid for supporting members navigating the system in different ways. And the reason that this is different than other navigation folks like traditional health workers is because we are really paying for the social needs connections. And it doesn't have to, while it should relate back to health, it doesn't have to have a medically necessary criteria attached to it, which is a little different than a lot of the other healthcare benefits that we have covered under the Oregon Health Plan. In January 1st, young adults with special health care needs are a new and eligible population. So that's 19 to 20-year-olds that have had some pretty complex healthcare needs in the past, comorbidities of different disease, disability. There's a lot of things that go into that, but they are now able to access the health-related social needs benefit, which is really exciting. And then I mentioned this, the nutrition benefit is also live as of January 1st. And then pantry stocking and a fruit and vegetable benefit will be coming later this year or into 2026, which is really exciting. Okay, so I'm not going to go into depth on this, but a lot of people have found this interesting, is that we've tried to do a lot of outreach and discussions with folks similar to this conversation that we're having here, or at least me talking and providing you information. 117 meetings that we had since March of 2024. We've had more than that, but specifically on really connecting with our HRSN service providers, the people that are doing the work on the ground with our members. Also, that includes people at the Oregon Department of Human Services, ODHS. So district caseworkers, district managers, APD and long-term care folks were involved in a lot of these conversations, because we want the people that are out there doing the work to know how they can connect their members to these resources as well. And we got a lot of good feedback. There was some focused and targeted feedback that allowed us to change our policy a little bit, to say, hey, our community is really telling us that this particular piece isn't working. I know they've changed some of the rates, for instance, in the past year to make sure that our service providers were able to sustain working on health-related social needs. Now, it's not perfect. There have been some challenges as well. I'll go to this slide and just mention we have these service providers. So 145, I'm sorry it's not super pretty, but I couldn't reformat it easily. But I wanted to share this with you and then talk a little bit about the challenges. And if you have any insight onto some of these challenges, then you're very welcome to email me or speak up as well. So right now we have 145 HRSN service providers. If you look at the map, you'd have to look in pretty closely, but you can see on the left, there's some coastal ones, and then there's a big focus on the metro area and down the I-5 corridor, which makes total sense. And then there's a few scattered in Eastern and Southern Oregon as well. We are working to build up our service provider network here. It's brand new, of course, and so we're trying to encourage folks and provide a lot of technical assistance to these service providers. We have every other month we have technical assistance, and then we also try to be available as much as possible, not just via email. Oh no, I spilled the water, sorry. Sorry about that. Didn't want it to get all over my my electronics here. But saying that, we're facing challenges of people feeling that people are not being communicated with, as in members. They are not sure of the status of their application. The service delivery and the paying the rental assistance sometimes can be difficult because landlords do have to provide some financial information to people paying rent checks, like a W-9, if you're familiar with that. Basically saying, yes, this is our address, it's on file with the IRS this way, this is the name of our organization. And so those are a couple challenges. How do we bring landlords into the conversation and make sure that they're comfortable accepting these rent payments? And then the other piece is, how do we make sure that people are served in a timely manner? The volume is incredibly high, and we prepared for what we thought was going to be a lot of demand, but I don't think anybody thought it would be quite this much. And it just goes to show you that people are really struggling with housing, especially out there. It's the housing benefit really kicked it into overdrive. People are asking for rental assistance and utilities assistance. They need help. And the reason I wanted to bring this up today, first of all, I'd love to hear any stories you have via email. I know we probably don't have a ton of time to talk today, but I'd love to be able to, come back and talk about some of the things that we're doing to help fix, I don't know about fix the problem, but support it a little better, giving CCOs a little bit more time while encouraging them to reach out to members, for instance. So you actually get, a quick phone call. Yes, we received this. It's, here's our time frame, and communicate back and forth with folks. I think that's a really important thing. We're also working at the Oregon Health Authority and with the CCOs and making sure that our provider network is adhering to Oregon administrative rules. We have certain time and distance requirements for our provider network. So ensuring that, people that live in Region A have this certain access to HRSN service providers as much as Region B, within reason, of course, because we have to incentivize our HRSN service providers to sign up as well. So those are some challenges. To be transparent, very challenging. We're talking about the timeliness and members being communicated with constantly on our team, and how can we do better. I wanted to, Nicole, please.
Yeah, so I just wanted to talk about something in particular. I am the VP of Customer Experience serving JCC, CPCCO, and I also have HealthShare's Customer Experience team. And to your point, we staffed for about 130 calls a day, and we are upwards of 560 calls a day just about this. And so again, there's extreme volume. I think one of the things that would be super helpful, and I know when this benefit was initially announced, OHA did some great media around it. But one of the things that I don't hear regularly discussed is the condition, the qualification conditions.
Mm-hmm.
And that, I think, is one of the problems that we're having, is when we have OHA representatives in different places, we're talking about this is a great benefit, and we're grateful for this benefit. But I think it's super important to make sure we're talking about that there has to be a health condition associated to receive this benefit. There has to be rent already established to receive this benefit. Because one of the problems we're having, frankly, is a lot of people are getting disappointed hearing, oh, if you're on Medicaid, you can get rental assistance. But then their reality is that they don't have a qualifying health condition, or they don't have rent established, for example. And so when you say, like, what could we be doing to help? I think starting off saying this benefit is probably going to be applicable to like 1 to 5% of people on OHP, starting with that, so people know this is not everybody on OHP. And then secondly, saying you have to have a household income that qualifies, a qualifying health condition, and a living situation that qualifies. That, I think, would be super helpful, so we're not disappointing so many people.
Thank you, Nicole. That was super helpful. And you are just 100% correct. I mean, we know that too. I've heard that recently, and I really appreciate that. I will absolutely take that back. And a few things you said made it really clear to me, some of the messaging that we need to do. One of the things that we are working on, so hopefully we'll have up in the next I hope by the end of the week, is a little bit of a disclaimer on our main HRSN webpage that says, a reminder, this is likely not for certain conditions, like you said. I think what you said was better than what we had before. So I'm going to try to use a little bit of that language, like, this is for a very small portion of Oregon Health Plan members. I understand how that would be so hard. I could get 6 months of rent and I need that so badly. And then to come and have them say, well, no, you need to have clinical risk factor and you make too much money and and the income is really low. I mean, for one person, it's all in Albany, it's 17,000 a year. That would be me. And that's pretty low as well. We have a lot of people that do make that amount of money, but the percentage, like you said. Anyway, I'm talking too much because I only have 2 more minutes, but I just appreciate that. I was actually almost done, so let me just take the next 2 minutes and show you. In fact, I'm going to skip. I won't skip. I'll point this out. This is Community Capacity Building Funds, or CCBF. I realized I didn't write that out on this slide, and I apologize. But just wanted to call out that the webpage for Community Capacity Building Funds should be up now or in the next few days, and the next funding period is coming through. And this will be the last one as well. It was just 2 years worth. These funds are intended to invest in our HRSN service providers, our community partners, to help them build up capacity as well for this. So, and then this is not something I'm going to talk to. I just want to make sure and include these, filling out the form here on the web page for members, and then getting some information like fact sheets and overview and eligibility. All these links are here. I'm going to send the slides to the folks that facilitate this meeting and make sure you get them. I could take 1 or 2 questions quickly if you would like. I'm sorry I talk so fast too.
Carissa, this is Nirmala from OHA. I just want to have a quick comment to the speaker who talked about the volume of calls. If you had that eligibility criteria well defined, like she mentioned, I think it would cut down on the call volume too, because then people would realize, hey, it's not a universal benefit. And so, people may self-select then and call when they think they're kind of meeting the criteria.
Yeah, we do have that. So that is posted. I think, though, if you go back to the news media that OHA did, none of that was said there, or the media didn't pick it up. So they're hearing this from their newspapers and things and then calling us directly. And that's where I think the big ask is, if I'm a representative of OHA, how do I lead with the criteria first and then talk about the benefit?
Yeah. Got you. Thank you so much. Sorry, that was a weird noise. I'm just thinking through this. This is the biggest priority for us this week, is trying to figure out how to message better. So really appreciate that. If you have any ideas, please email me. I'm putting my email in the chat. I'm generally pretty responsive if I'm in office. And yeah, if you have any ideas and thoughts, that would be great.
Teresa, thank you so much for your time today. We greatly appreciate it. Thanks for being able to adjust on the scheduling piece too. That's much appreciated. And you read my mind on asking for your email and popping it in the chat. So even better. We are at 1:46. Let's go ahead and take a couple minute bio break. We'll be back in at 1:50 where we'll resume.